We've begun to think of multiple myeloma as a disease that's driven by certain translocations, in some cases involving the heavy chain gene and specific partners. So we think about translocated multiple myeloma, and we think about hyperdiploid multiple myeloma with some overlap. We know that certain of these translocations confer a negative prognosis, and they've been integrated into the international staging system for multiple myeloma. This is the T414, 1416 translocations, as well as deletions of the short arm of chromosome 17. So we're building these translocations into risk stratification systems. We've also, independently of the formal staging systems, identified various populations that carry more than one of these translocations or other certain chromosomal abnormalities that certainly confer negative prognoses. Sure, it's a very broad topic and a very exciting topic. When I think about BCMA-targeted therapies, I think essentially of four broad categories, and these are the chimeric antigen receptor T cells, or CAR T cells, which have gained a lot of press recently. We also have bispecific T cell engagers, antibody-drug conjugates that target BCMA, and finally, in early stages of development, there are naked antibodies against BCMA. And so many people are now familiar with the CAR T data with anti-BCMA CAR T cells, which have shown high response rates with various CAR T constructs. And at this meeting and previous meetings, there have been new data presented surrounding bispecific T cell engagers, including the AMG 420 product, which showed a relatively high response rate in the single agent setting, and the antibody drug conjugate belantamab mafodotin, which has an antimicrotubule payload and has new emerging phase 1/2 data that's come out both here and in previous meetings. So anti-BCMA therapy is a broad topic, and it's an emerging topic, and we're going to need to work to understand which patients should receive this type of targeted therapy, and how to overcome resistance that emerges from variable BCMA expression, both within individual patients and across populations. So those are some exciting questions for the future. There are many emerging targeted therapies that are very interesting. There are many antibody-drug conjugates that are targeted against other antigens outside of BCMA. So there are a couple of products that are targeting CD38s. There are other products targeting CD56, for example. All of these products are still in early phases of preclinical development or very early clinical development. Additionally, there are various vaccines that have been tried in multiple myeloma, including vaccines that are now conjugated to autologous dendritic cells to expose the immune cells of the patient to a broad range of myeloma-related antigens. There are also exciting targeted therapies involving anti-SLAMF7 antibodies, which are relatively well known at this point, and new anti-CD38 antibodies, in addition to daratumumab, isatuximab, and other early stage products. Finally, there are checkpoint inhibitors that have been in development. The development's been slow due to a high degree of adverse events in some of the earlier trials, but we're still exploring combinations of checkpoint inhibitors and more conventional immunomodulatory therapies in multiple myeloma. So that is a very difficult question, and one that we're still struggling with in the multiple myeloma community. We do know that there are certain associations between cytogenetic or molecular abnormalities and improved response. For example, the most striking example is venetoclax in 1114 translocated multiple myeloma, but there are others, including the proteasomes in T414. So slowly we're beginning to match specific treatments to molecular subsets. I think the challenge is going to be designing trials based on these molecular subsets and also integrating very important patient-related data. For example, frailty is a favorite topic of ours at NYU, and thinking about not only which therapies are effective, but which therapies are safe, and how to sequence therapies. So as we develop new this excellent armamentarium of targeted therapy, we're going to need a little bit more data, but we're going to need to be really precise and rational about how we design clinical trials. So at this point, I can't give an algorithm for how to integrate all of these exciting therapies into the care of any specific patient. I think that map's going to become more and more clear as these therapies progress to later stage trials, and that some of this information disseminates into the broader academic community and into the community of hematologists and oncologists at large. So maybe not the most satisfying answer, but I think it's the best we can offer at this point, best I can offer at this point. So one interesting element of the molecular segmentation of multiple myeloma that I didn't address when you asked me earlier was that while we are fairly sure what's going on at a chromosomal and subchromosomal level, the landscape of single gene mutations or single nucleotide variants in specific genes has been less well connected to prognosis and disease progression. But we do know that many patients, about 40%, harbor mutations in the RAS MAP kinase pathway, and an additional 12% harbor mutations in the NF-kappa B pathway. So there are phase 1 trials and early preclinical trials looking at agents that act in specific points in these pathways. We have the BRAF-directed therapies already in multiple myeloma that seem to be effective, but due to the fact that those mutations are typically subclonal, there are high rates of relapse. I think that actively exploring the implications of mutations in the RAS MAP kinase pathway and the NF-kappa B pathway could be interesting, but there are several other, in addition to that, several other interesting pathways we could be looking at.